um, as people kind of start tuning in, and as anybody tunes in, please mute yourselves as y'all tune in. It is my privilege tonight to introduce one of my friends and somebody who's really having a major sacrifice tonight, joining us, not getting to watch the first half of the Eagles Chiefs game. So Meredith Osterman doesn't need a lot of introduction, but as y'all know, she is a expert in many things. One of the things that she and I share a passion for is arthroscopy, and we're really lucky to have her come and teach us a lot of the amazing stuff that she does. Meredith, thank you so much for joining us. You have a mixture of med students, residents, fellows, therapists, so kind of the whole research assistants, so the whole and faculty, so whole gamut, and more people kind of be signing in and out. I'll make sure that everybody's muted as we do it. So the floor is yours, and just towards the end, we might do 5 to 10 minutes if it's okay for questions.
Yeah, sounds fantastic. Thank you. I can't say I'm an expert in everything I'm going to talk about, but it's stuff I'm interested in and still trying to figure out. And maybe the discussion will prompt you guys to help me answer more questions. But let me try to see. Technology is not my strong suit. Can you see my screen?
Yes, that looks great.
Yes. Okay. So I am going to talk about some of the new indications that I am playing with wrist arthroscopy, and mostly talk about scapholunate ligament injuries and dorsal capsular injuries, and then kind of quickly finish on perilunates. And then happy to talk questions and so forth. So, similar to many of the master arthroscopists that you all are exposed to, Dr. Wagner, Dr. Sue, and more, arthroscopy is a really exciting tool. And as I've gotten more comfortable with it, I've started to incorporate it more in my practice. And I think whenever you're incorporating something new, you really need to think about, well, what are the benefits that this tool or this technique or this instrument can provide to me to deal with some of the challenges. And so, especially when we look at different problems where maybe we don't have a perfect solution for, this is when we want to start thinking outside of the box. How can we solve this problem and come up with new and creative solutions? And so if you think about some of the surgeries and some of the pathologies we've seen, there's a few that have multiple surgical options, right? So you think about CMC arthritis, and patients come in and they get to the point of surgery, and there's really just a plethora of options that we can provide for our patients. And it's really because they all work. There's benefits and pluses and minuses to all of them. But the reality is everything we offer them truly works. Then you have something like scapholunate injuries and carpal instability. And again, there's a multitude of surgical options, but it's really because none of them work. And why is that? And kind of my thoughts on it and my feeling is that we have just been so focused on the intrinsic scapholunate ligament and not really focusing on a lot of the secondary stabilizers in our treatment algorithms that that's why some of the surgical outcomes are far from ideal. And hopefully I'll kind of show you that throughout. So when patients think about, all right, I'm going to be treated open or arthroscopically, for instance, for a scapholunate, this is what they're seeing. Well, what are we talking about? So arthroscopically, we talk about debridement and capsulorrhaphy, maybe pinning. We talk about arthroscopic SL repairs or reconstructions, or dorsal capsule and DCSS repairs, which is what I'm going to focus on tonight. When we talk about open procedures, there's capsulodesis, there's reconstructions, and there's a variety of kind of Sanj Kakar's 360 and Dr. Wolf and his team's Anafab. And, when you think about arthroscopically, these are minimally invasive. And really the benefit here is less postoperative scarring, less postoperative stiffness, and it allows a better understanding of all the structures that are involved. And when you do these open, you obviously can see more clearly. You have a big open approach, but this can lead to increased stiffness, and it really doesn't allow you to assess and treat the secondary stabilizers. And so arthroscopically, I think there's a real win and an opening here to utilize arthroscopy to understand the role the secondary stabilizers are playing in the pathology and not damage them on the way in, which can then lead to decreased stiffness. I do think there's quite a steep learning curve to a bunch of these procedures, which ultimately in the beginning can be a bit of a time suck and also a cost to you as well. So let's talk about the major player here, right? The Batman, the scapholunate ligament. And when we think of this injury, we think of the intrinsic ligament with the dorsal, the intramembranous, and the palmar portion. But we cannot leave out the sidekicks, the secondary stabilizers, and really specifically for this, those dorsal stabilizers. So the dorsal radiocarpal and intercarpal ligament and the DCSS. And so the extrinsics, we know volarly, we have the radioscaphocapitate, long and short radiolunate, the STT complex. But then dorsally, it's that DIC and the dorsal radiocarpal ligament that are hugely important. And so when we look at the DRC, so rises from the radius, inserts onto the triquetrum, but most importantly, it has fibers that are connected to the lunate. And so even though there's a variety of anatomical variations, they all have some fibers that are attached to the lunate. And same with the DIC, which comes at a more longitudinal orientation. There's also insertions on the lunate, and there's been a variety of anatomic and imaging studies to support this. And so both these structures insert onto the lunate, and this plays a hugely important role in carpal stability. There's constraints to VC and DC, but most importantly, this supports the intrinsic scapholunate ligament. And so when you have tears of the DRC and the DIC, them by themselves can be implicated in carpal instability, but then they can also exacerbate instability from an intrinsic scapholunate ligament. These structures can also be a source of dorsal wrist pain on their own, and Slutsky has shown this. This is often a very difficult thing to diagnose. Often imaging is pretty normal, and patients have this kind of non-specific dorsal wrist pain. And if you don't make a volar portal, it can be very difficult to see these structures. So the volar portal is made through the long radiolunate and the radioscaphocapitate, and it's made from more an inside out. So you want to drive a trocar volarly and then make an incision because there's some important volar radial structures we want to get out of the way. But through a volar portal, you can then look back and see the dorsal structures. And if you use the old Lymphatech tower, which we use, this is actually very difficult. So it's motivation to get some of the newer towers in your system. But this is looking from volar to dorsal. The probe is just at the SL ligament right there. And you can see all that dorsal capsule that's basically torn off of its insertion point, all this thickened dorsal capsule. And so this can be a source of dorsal wrist pain for patients if you think, especially as they come into extension and axial load. So these patients will say, I can't do a push-up or I can't weight bear without pain. And then if you look at these patients in their mid-carpal joint, often you will see instability at the scapholunate interval, even if the scapholunate ligament is intact. And I'll show you a little bit more of that coming up, but you can repair this structure. So you can repair the dorsal fibers in a very similar technique that we do when we're repairing the TFCC with capsular repairs. You can use 18-gauge spinal needles if you don't want to use some of the kind of fancy meniscal mender kits, and you can pass a suture around the dorsal capsule and basically kind of reef up all of that lax tissue. And then you would want to just tie this under the extensor tendon. So now if we're pulling that suture, you can see it's passed dorsally. And if we look back volar, you can really reef up that tissue and repair it back. And then you would just tie it under the extensor tendons. And there's been some papers to show good results. And I can tell you from some of my own patients, these are some of the happiest patients. These are patients that kind of go undiagnosed for a long time because it's very difficult to appreciate these injuries unless you look at them arthroscopically. This is a case I just did last week. This is actually looking from the 6R portal, and I have a needle. And this is the one time, in addition to doing a ganglion excision arthroscopically, where I'll make my 6R portal first, because I really want to make my my radial portal under direct visualization. I want to put it in a spot where I'm going to be able to get my shaver or my sutures across. So I'm looking back and you can see all of that redundant, torn dorsal capsular tissue that's synovitic, that's just getting pulled directly into the joint. And oh, sorry, my video is freezing. There we go. And again, you can see the scapholunate ligament is intact in this patient. And as we drive up You can again see that dorsal capsule that's very thickened and torn, and the scapholunate ligament, which is intact. And then if we drive up, you can follow that dorsal aspect of the scapholunate ligament and see the DCSS, which is that arc of tissue that connects the dorsal capsule to the scapholunate. But this patient, if you look in the mid-carpal joint, they do have some step off. So you're looking at some instability here at the scapholunate ligament or scapholunate interval, despite the fact that the scapholunate ligament's intact and the DCSS is intact. But because that dorsal capsular tissue is ripped off, this is a patient that's going to have a pre-dynamic instability. This is not a patient that you're going to see a huge, wide Terry Thomas sign on your grip views. This is a patient that their x-rays are going to look pretty normal, but you can appreciate that there's instability. And the way you can address that is by treating the dorsal capsule. And I will show you that more. So I keep talking about this DCSS. What is that? The dorsal capso-scapholunate septum. This is basically a tether between the dorsal aspect of the scapholunate ligament and the dorsal capsule. So it's really where these two important players kind of connect and come together. And so here you can see you have your scaphoid, you have your lunate. This is looking from ulnar to radial. You have your scapholunate ligament, you have your dorsal capsule, and then the DCSS is that kind of arc of tissue that connects the two. Here is looking arthroscopically from, again, ulnar to radial, and this is an intact and pretty healthy DCSS, and you can really ride the entire scapholunate ligament up to find it. And there's been cadaveric studies to show that it's consistently found. And it's pretty obvious to see when it's injured. Here you can see on the right, there's really no congruent tissue, and there's complete injury of the DCSS. And so what role does the DCSS play in scapholunate instability? Where this was a study where arthroscopically, they sectioned the DCSS and then quantified the amount of instability. And what they found was there was increased SL instability, but this could only be appreciated arthroscopically. So when we classify, there's two classifications. There's the Geisler and then the EWAS, and this is all classifying instability arthroscopically. So when you section the DCSS only, these again are not patients that you're going to see radiographic changes. These are not patients that come in with a wide SL diastasis on x-rays. These are not patients that are in DC. These are patients where their x-rays are going to look pretty normal, but arthroscopically, you will see that they have instability. And so they really showed that the DCSS is a really important secondary stabilizer that then ultimately, by addressing it, can have important therapeutic implications. So the way that I've started to really think of these injuries is not as scapholunate ligament injuries, but more as a scapholunate ligament complex. And there's been many studies over the years, starting with Dick Berger from Mayo all the way back in 1999, that really showed the importance of all these secondary stabilizers, but we've never really incorporated them in terms of how we think about things. And so I really think we should think about this as a structure that has three structures: the scapholunate intrinsic ligament, that DCSS, and the dorsal capsule, and then these three arches that really all need to be addressed at the time. And Rush talked about this, again, decades ago, talking about how when you have a tear of the dorsal capsule, this showed a much greater degree of carpal instability, and it would change ultimately their treatment options. And there's a multitude of studies, again, that have shown this. So if you think about it, or you're still not convinced, riddle me this: that every SL instability does involve some degree of SL ligament injury, but not every SL ligament injury causes SL instability. So you can tear your scapholunate ligament and not necessarily have instability if the other secondary stabilizers are intact. You still don't believe me? Here's a cadaver where first we're going to section the scapholunate ligament only, and you can see there's definitely a degree of instability. Now we're going to section the DCSS and the dorsal fibers. And again, you start to see more gapping, more instability. Here's with axial loading. But then once you section that dorsal capsule, that's when things really take a much bigger change. And so what if we can just fix the DCSS or the dorsal capsule, and what role will this play in addressing instability alone? And Mathullin and his group have shown this and described a technique where arthroscopically you're passing a suture through the dorsal aspect of the scapholunate ligament, through the DCSS, through the capsule, and repairing these structures back down. So in this first video, this is looking in the radiocarpal joint. You're passing needles through the radiocarpal joint into the midcarpal joint, and you're passing sutures to then pass a stitch. And here's some schematics to kind of help go along with the videos. And then here's passing a stitch, and then tying it extracapsular. Here's passing the suture down and tying the knot. So that's the schematic, and I'll kind of show you what this can do. So here is a patient. This is looking in the mid-carpal joint. You can see that there is some step off. This is a patient with an intact scapholunate ligament, but with a tear of the DCSS. And you can see that instability passing needles from this is looking in the the radiocarpal. To pass the needles, you grab the suture in the mid-carpal joint, and this is for a passing stitch. Let's go to, there we go. And then you're going to pass your suture back down and tie it extracapsular. And then this is the degree of instability you get from that afterwards. And I think I have, here is the before and the after. So you can see there's a huge amount of support that can be gained from suturing the DCSS alone. And again, this is a patient with an intact scapholunate ligament. And so there's also the issue of what if the capsule alone is actually ruptured from those attachments. We talked about how the DIC has attachments to the scaphoid, but both the DIC and the DRC have attachments to the lunate. And so if you have a patient that has the capsule, the DCSS may be intact or not, but the capsule itself has pulled off of its lunate attachments, well, you can put an anchor either into the scaphoid or into the lunate, depending on where that attachment has pulled off. In a very similar fashion, use the sutures from that anchor to then pull the tissue back down to its attachment on the lunate or the scaphoid, although I'd say more commonly this happens from the lunate. So here is passing the sutures from the anchor. Now, I tend to just actually connect these two portals at this point and make an incision to ensure that no extensor tendons are caught. So I would recommend doing that, especially in the beginning. But then as you tie this down, so now you're going to watch that capsule repair itself back or bring itself back down to its attachment on the lunate by putting the anchor and passing that stitch. And that's going to help you impart the instability or repair the instability. So Mathieu and his group have shown some of their results. These were 10 case series that all these patients had intact scapholunate ligaments, but all had Geisler instability diagnosed on midcarpal arthroscopy. And they were found to have that instability because of detachment of the DCSS. These were repaired in that fashion that we just talked about. And again, these are all patients with pre-dynamic scapholunate instability. Here were their preoperative values. And at 1 year, all of the improvements, there was improvements in all parameters from range of motion to grip strength to dash scores. This is further data from 2018. These are patients that had EWAS grades of a 3 and above. So these are where there's instability, either volar, dorsal, or combined. None of these patients had SL diastasis. So these, again, are all diagnosed arthroscopically and all had correction in their pain scores, range of motion, and grip strength. Now, Mark Ross and Scott Wolf and others have taken this even a little bit farther to kind of expand on this DCSS concept and said, really, we should be repairing more than just the DCSS, but also combining more of a capsular repair. And they call this the radical procedure. So reduction, augmentation of the dorsal intercarpal ligaments. So doing kind of a combination of putting an anchor to that bare area on the lunate as well as repairing the DCSS. And, people are starting to push the envelopes even more, doing this in patients that come in with even more than that pre-dynamic instability, with patients that do have pretty advanced gapping and instability. So this is 112 patients, all with EOS stage 3A and above. So these are patients that even have a drive-through sign. 12 of these patients had a drive-through sign, all treated with a dorsal capsular repair, a DCSS repair, and all had significant improvements. So when we think about treating these open, despite this, the ligament splitting capsulotomy, which is we all kind of think about as the most preserving, this really doesn't address any of those secondary stabilizers I've talked about. In fact, if they're intact, the exposure alone will injure them. Additionally, closing this does not address any of those lunate attachments. So really, all of these capsular exposures really violate all of these secondary stabilizers. Now, Scott Wolf has come up with a way to manage that, doing what's called his window technique. So you maintain those lunate attachments of the DIC and the DRC and kind of work on various windows. Again, this is all if you're feeling the need that you need to treat this open. And he did a study looking at the Berger kind of fiber splitting technique versus his, and found the window approach preserved more of those ligament stabilizers and did not produce much changes in carpal posture, which again makes sense. You're keeping all of those attachments to the lunate. Here's a couple of my patients. This was a 59-year-old. She presents 1 month of dorsal wrist pain after a hyperextension injury at a Phillies game. Now, I had seen her before because she had ulnar impaction. So I actually had grip views from her from 2 years before, which was very helpful here. But she presented with a relatively benign exam. She was tender over the dorsal SL and LT area, pain with Watson's, but she did not have instability. And she had a little laxity that was equal to her contralateral side. And here are her basic x-rays, pretty unremarkable, but on her grip view, in addition to the ulnar impaction, you can see that she does have some widening on the right side compared to the left. And again, I had x-rays from a few years back to show that this was something new. Her MRI was pretty unimpressive, aside from the ulnar impaction, really didn't show anything very significant. And so ultimately went in arthroscopically. So in this first video, you were looking from the ulnar aspect, looking radially. You can see the scapholunate membranous portion is intact, but as we come up dorsally, you can see that there's a tear in the dorsal fibers of the scapholunate ligament and the DCSS. And this is with fluid, which I do a lot of, not to digress, dry arthroscopy now. But this obviously, you can see the air bubbles and you can see how annoying they are, hence part of my transition to dry arthroscopy. But you can see that the DCSS is torn. The dorsal aspect of the scapholunate ligament is torn. And so the treatment for this was that dorsal capsular repair. Here was her mid-carpal joint pre-tensioning, so you can see that instability. And then in this middle one, this is after we pass the sutures and we're pulling them taut. And I want you to watch what happens to that step off as the ligament is pulled. You can actually see that whole reduction occur. So I was with one of the fellows who does not very trusting of this technique until he saw this happen as he pulled down on the suture. So it's actually quite impressive. And then here she is afterwards, where there's really, again, if you really compare side to side, it's quite impressive. And then looking from the ulnar side, you can see that that capsule has been kind of repaired down to the dorsal aspect of the scapholunate interval. This was another patient, an 18-year-old, hit the boards during a game, hyperextension injury, pretty weak with his grip strength, had pain with a Watson, some dorsal wrist pain. But again, this is not one of those patients that's clunking in and out with a Watson's exam. X-rays, pretty unremarkable. Grip views, unremarkable. His MRI was interesting. He had a big lunate contusion and actually had an avulsion fracture of just the dorsal aspect of the lunate, but that avulsion included all of the dorsal capsular tissue. So essentially, he had a big dorsal capsular avulsion off of the attachment onto the lunate. And so trialed him with non-operative treatment, but he was unable to return to playing, so ultimately went in arthroscopically. And so this is some images looking from ulnar to radial, and you can see all this dorsal capsular tissue, synovitic, inflamed, and a volar portal. This is a great opportunity to make the volar portal where you can really see all this dorsal thickened capsule. And here, what you can see is the scapholunate ligament sac, the DCSS is intact. So this is not a scapholunate ligament problem. This is not a DCSS problem. This is a capsular problem. And when you look at him in the midcarpal joint, again, you can see that there is some step off and instability. You can't get the probe in. It's not a scapholunate ligament problem, but this is a predynamic scapholunate instability. Oops, this video is glitching. Sorry, this video is glitching. But basically what we did, I put in an anchor. Let's see if it will work now. Sorry, put in an anchor in the lunate and then tied that capsule down. So what if you get in and there's a huge drive-through sign and you're just not really comfortable that doing this repair of the capsular DCSS alone will work? Well, there has been reports of actually arthroscopically reconstructing the scapholunate ligament using an Arthrex internal brace, which many of you have probably seen open before this technique. For full sorry, all these videos are starting to glitch for some reason. For full disclosure, I don't do this procedure, and I'm sorry, none of these are showing very well. But this kind of shows you the technique, which is very similar to doing it open, where you're just going to put a suture tape across the scapholunate ligament and then move forward with the other procedures I talked about. They make it look quite easy. Again, I don't do it myself, but I thought for completeness sake, I would show that. You can do this technique that we talked about in the dorsal fashion. You can also do it volarly, and Sanj Kakar has talked about this, where in a similar fashion, if you notice that the interval is gapping volarly, as you can see on image B here, you can pass the suture in a very similar fashion using the spinal needles and pass them out volarly. And so on image F down here, this is tying the knot volarly over the volar capsule. So you retract the FCR, make sure you protect your nerve and your artery radially, and then you can tie it, and that's the same. So we need to start thinking about these injuries as not just the Batman, not just the intrinsic scapholunate injury, but as a complex cast of characters where there's components from the dorsal capsule and then also the DCSS, and really start thinking about a complex that includes intrinsic and extrinsic characters. So what's my algorithm? Well, first, these patients often show up and they have that dorsal wrist pain. They have difficulty axial loading, and often their exam shows some pain dorsally, and their x-rays are unremarkable. And so I usually put them through the non-operative algorithm first of splinting, possibly an injection, anti-inflammatories, because typically when those patients show up with dorsal wrist pain, inability to axial load, on my differentials, a dorsal ganglion, a scapholunate ligament injury, or a dorsal capsular injury. And some of those patients can heal non-operatively. If not, I move towards arthroscopy. And the things that I think really determine the treatment is, first and foremost, is the SL reducible? So when you look in the midcarpal joint and you can reduce that scapholunate step off, then I would try an arthroscopic repair of either the dorsal capsule, the DCSS, or even the scapholunate ligament. If the SL is not reducible, that is going to warrant an open procedure, because you're not going to be able to reduce that with a soft tissue only procedure of the capsule. And obviously, if there's arthritic changes, you can do a salvage procedure. And then there's always the discussion of just doing a synovectomy and a wrist deinnervation. And that, I think, should be part of your algorithm as well. If you're going to open, there's a variety of options. I think the big key is that extracapsular component. So making sure to address all the secondary stabilizers. And I think these techniques do take that into account more than the other options that are out there. All right, so I've beaten this to death. I'm just going to move on very quickly to perilunates. Perilunates are something that are not common, but I think we're all familiar with the mechanism. And despite it being quite a traumatic injury, and quite dramatic on x-rays, these are really commonly missed, which is very detrimental, as worse prognosis is with a delay in treatment. I think many of us are familiar with radiographic findings. A lot of this is more important for ERs and for primary cares that may see some of these x-rays, but you're looking for a shortened carpus, that triangular lunate capitate overlap, sometimes the cortical ring sign, any type of fracture. And I always tell the ER residents, I mean, if there's ever concern, just get a x-ray of the contralateral side. If you need a comparison, you can always get it from the patient themselves. You'll often see the lunate sitting volarly, you'll see the capitate off. And so when we think about treatments, the biggest thing is promptly diagnosing these and treating them open. There's very good data to show that closed treatment in a cast is not ineffective for these. But even if you look at the results from open treatment, only 75% are successful. Despite if you go dorsal, if you go volar, if you do a combined attack. And a lot of that, I think, is because of such a significant injury that we create in repairing these. I mean, a lot of times you have to go dorsal or we go dorsal and volar, but sometimes I think it's more out of habit than actually what you need. Obviously, if there's median nerve symptoms, you have to take into account that. And a lot of times this is what the x-rays look like afterwards. But what if a patient comes in like this and you're able to reduce them so that you have perfect alignment? And we go back to the treatments or the steps that are needed to treat these. So if your closed reduction yields anatomical alignments and we've addressed the nerve symptoms, either they don't have any median nerve symptoms, you've maintained their anatomical skeletal reduction, then it's really about the soft tissue repair and maintaining the reduction. So we just talked about these cast of characters, all these different players that play a role, that it's not just about these intrinsic ligaments, the scapholunate and the lunotriquetral, but we can use arthroscopy to preserve and protect all these other players and not violate them to go down and repair the scapholunate and the LT. And I'm sorry, all of these videos are starting to glitch for some reason, but this is a patient, that arthroscopically is getting treated after a perilunate. Goodness gracious. Sorry, this one down here, you can see a little bit better. You can see the instability of the lunate popping all around. On this top view, if it wasn't spazzing out, you would just see lots of synovitis. Obviously, you see the scapholunate ligament torn. But so you can go in arthroscopically and do a synovectomy, do a thermal capsulorrhaphy. And as long as you can maintain the reduction, then you use K-wires to hold things into place. You can also use headless screws if you want. And there's a lot of literature that supports this, about the role that arthroscopy can play in treating perilunates and the benefits of it as well. So this was 5 patients, all treated arthroscopically with reduction in percutaneous fixation, mean follow-up of 17.8. But look at these results. Range of motion, 84% of the contralateral wrist. Grip strength, 90% of the contralateral wrist. Just those objective numbers, you will never find that with open perilunate treatments. These patients are so stiff, let alone dash score of 1, excellent Mayo risk scores. And so they really show that arthroscopic reduction, percutaneous fixation is reliable, but it's also favorable when you start thinking about treating these patients. This was 20 patients, 11 treated open, 9 treated arthroscopically, follow-up of 2 years, stability achieved in all of them. Stability is rarely the issue. These patients get so stiff, but the arthroscopic group had improved dash scores and greater range of motion. This was one of my first patients. I tried this on 25-year-old motor vehicle accident. The fellow's got wonderful reductions. And so we went in arthroscopically. I hope this video will cooperate. Can see lots of synovitis. A lot of times you really have to flush this out. It's very kind of bloody initially, but you can of instability of that lunate. So we go in and do a synovectomy, reduce it. We use headless compression screws for this patient, remove them at 4 months. And this was at 8 months, and he's kind of lost to follow up. But even at 8 months, range of motion was pretty good. Alignment was maintained, and pretty good grip strength. And so just like scapholunate instability, we need to think of perilunates as being on a spectrum. Just because a perilunate walks in the door does not mean you have to open volar and dorsal. A lot of it depends on if you can reduce them anatomically. And so when you think of these injuries and the cast of players, start thinking about how arthroscopy can play a role and how you can incorporate it into your practice. And I think we will find that it allows for better outcomes in the long run. So thank you so much for your time. And happy to answer any questions or just disappear if that was too much information and too much superhero talk.
Dr. Osterman, thank you for that talk. I'm Joe. I'm one of the fellows. I think between you and Dr. Wagner, I'm becoming a convert in the arthroscopic management of SL injuries. I have a question for you actually about how you manage these patients before surgery in the office when they first present. You mentioned that you go through your non-op algorithm. If you have someone who comes, like the patient you presented that hyperextended her wrist at the football game, with a pretty convincing story, pretty convincing exam, you're pretty confident it's an SL complex injury, do you still trial non-op or do you offer her surgery right off the bat? And I guess a follow-up question is, do you always get an MRI if the x-rays are normal, since we know arthroscopy is more sensitive, or do you go right to arthroscopy?
So great question. So as far as the MRI, I don't think MRIs are helpful in this situation at all. I end up getting them most of the time, and that's kind of a separate kind of discussion. Part of it's because of patients' demands now, right? A lot of patients come in and they want MRIs, they want further imaging. A lot of patients even come in with MRIs already, especially in our institution. A lot of them are referred from primary cares who will kind of work up the patients already. And so I don't find it to be helpful. I find I get them a lot to satisfy patients more than myself. You know, sometimes when a patient walks in and you say, all right, let's arthroscopically check this out, they kind of look at you and say, what do you mean? You're not going to get an MRI and figure out what's wrong first, you know, despite what you explained to them. So I often get MRIs more for kind of psychosocial reasons more than diagnostic purposes. The times I do think it's helpful, if I think a ganglion's playing a role, sometimes if I really think it's more of a ganglion rather than a scapholunate complex injury, sometimes that can be helpful, but I take out a lot of ganglions arthroscopically now as I've gotten more comfortable. So that's kind of shifted a little bit over time. As far as treatment algorithm, you know, it's pretty individualized. I think, again, a lot of it, patients come in, and even though they're coming in to see a surgeon, they shy away with the idea of surgery right off the bat. And so I think it does help to establish a bit of a rapport with patients, to talk about some of the non-operative management, offer a trial of splinting for 3 to 4 weeks, let things quiet down and calm down. And I do think there are some patients that probably go on to heal these things to some degree. But I often do mention surgery early on in our discussions, and you kind of can see where that goes. Some patients jump on it. They're like, look, if you think I'm going to need this and this is the best way for you to understand my injury, let's just do it. And that first woman, that she was really on that bandwagon. She had known me for a while she had been talking about her impaction lesion bothering her. She's like, you can deal with that too at the same time. Sounds good. And then there's other people that kind of, start to get sweaty and vasovagal when you mention surgery. So I think some of it is individualized and kind of feeling out the patient's goals and their comfort level. In that second patient of mine, the hockey player, even though I had the MRI that really kind of told me what I needed to know. I mean, I thought that MRI was one of the first ones that was quite helpful to me. He's an 18-year-old hockey player, and parents weren't really keen on surgery right off the bat. So 6 weeks in a splint made sense. So I think, you kind of have to feel out the situation to some degree. I mean, in my mind, I would love to just go in arthroscopically in all these patients. I think it would be efficient. It would be so helpful for me to understand the injury. But the reality of kind of gaining that trust with patients, surgery is not always the best thing right off the bat. The recovery for these are long too. I mean, you're talking 3 to 6 months. So it's not something too, you kind of want patients to feel like they really need it as well.
Awesome. Thank you.
Thanks, Dr. Osterman. Great talk. I'm Tom. I'm the other fellow. I didn't fully introduce myself earlier. My question for you is, I'm wondering what the role of the chronicity of the patient's timeline plays into your algorithm. You mentioned that a lot of your algorithm is predicated on how reducible the SL interval is intraoperatively, rather than looking at IWAS or grading necessarily. I assume you're sort of using your probe and seeing if it's reducible and deciding if you're going to do a DCSS capsulodesis. In your mind, if a patient is more chronic in terms of their story, does that lean you more in the direction of, it sounds like you do more of a open SL reconstruction, or is chronicity not as relevant and you stick to that reducible algorithm?
Yeah, chronicity is not relevant to me at all. It really is how reducible it is at the time of surgery. Because I mean, I've had patients that have been walking around with kind of this soft dorsal wrist pain for years. You know, they'll say, yeah, I could never really do a push-up. I've always kind of had some pain, you know, maybe from a cheerleading injury a decade ago, but in the past 8 months, 10 months, it's getting worse. And now, you know, so I don't know if there's, you know, especially in these kind of hypermobile young women, that maybe there's a degree of kind of instability built in, and then they kind of, you know, rupture it a little bit or stretch it too much. So I haven't found, I mean, again, these are not ones where I'm doing 2 every Friday, right? I mean, these are not cases like carpal tunnels where you're building up. I've probably done, I don't know, maybe 25 or 30 total right now. So I'm still learning a lot. But I've been surprised how, you know, some of these patients that say they've been kind of dealing with it for almost like a decade to some degree, and you go in and it's reducible. And so I think, why not try to fix it arthroscopically? So that's really my big cutoff. It's the reducibility. And I think sometimes these, I mean, patients say, oh, I fell downstairs, you know, the moment of the injury, but sometimes these patients come in and they don't know when it started. There wasn't necessarily a traumatic moment. So I think these have the potential to be something that just kind of worsens over time too. You know, you may have a little strain in the dorsal scapholunate over time. It just elongates and then it stretches into the DCSS. And before you know it, they have a complete, you know, pre-dynamic instability that may have just started as a sprain years before. And I don't think there's a lot of good data on kind of understanding how the chronicity plays into it. So for me, it's reducibility and obviously any arthritic changes, which usually you do have the ability to know preoperatively.
If they have a static deformity, will you do arthroscopic capsulodesis, or is that in your hands always an open procedure?
That to me,
if it's reducible still.
If it's anything reducible, I will try arthroscopic. Yeah.
Awesome.
Yeah. I mean, I think, you know, it's some of it's not necessarily closing the gap even too. I think a lot of it is like preventing that dorsal translation of the scaphoid on the radius. I think that starts to be more of an issue. We focus on the gap. We're always focusing on the gap, but you see all these people with slack wrists walking around and don't hurt at all. So I think a lot of it has to do with the amount of that translation of the scaphoid on the radius dorsally, the amount of instability that the patient feels. So I go for, I mean, what's the worst that can happen? It's, you know, they don't do well. You treat them arthroscopically. It's reducible. They don't do well. You haven't burned a bridge. I mean, these open procedures are no joke. I mean, they're fun when you're a fellow. They're fun when you're a resident. But when you're doing them on your own and you're managing these people, I mean, yeah, some of these people do great because they have like 20-degree arc of flexion or arc of motion because they're just so darn stiff, you know? I mean, Sanj Kakar makes it look so easy and he gets these great results. It takes me 3 times as long to do hit the 360 as him. So I don't think they're the answer for everybody too.
That makes sense. Meredith, yeah, thank you very much. This was like absolutely great, absolutely wonderful. I love the yeah, you're very eloquent speaker. It's very fun listening to you. Quick question. Actually 2 questions. One, you know, you referenced Sean's article on the volar. When are you doing a volar capsulodesis, if at all? What do you think the role is for that? And then, are you applying any of these same things to any LT that you see, or are you just not seeing any LT that would be applicable?
So I love ulnar shortening. So when I see an LT, I love to shorten the ulna.
There you go.
Like my favorite surgery is an ulnar shortening. So it
Perfect.
probably could translate some of these things over. I don't think the capsule is as robust, and I haven't seen any anatomical equivalents to the DCSS over there. Maybe we just don't know them yet. I don't know. But yeah, for LTs, I go straight to the ulnar shortening. For volar, so, this is tricky. I mean, Sanj is really pushing the boundaries, and even in these really, really like EWAS 5, like drive through, I think he's done 2 now where he's done the dorsal capsular, like the dorsal capsulodesis, like we talked about here, and the volar. So he's kind of repairing both sides arthroscopically. I haven't kind of entered into that world yet. I've only done 1 volar, and what I found arthroscopically when I went in is there was a little bit of step off, but if anything more, what I found is the volar side just gapped open. So you could kind of get the probe in volarly and do the whole rotation, but you couldn't do that dorsally, and there wasn't the same degree of step off between the scaphoid and the lunate. So that was the one time I've done it volarly. It was surprisingly easy. I actually found it to be way easier than doing it dorsally. Dorsally, I still, the videos make it look kind of sexy and everything, but I still struggle sometimes getting the needle in, and then you're back and forth, and you're like trying to bend it, and it can be tricky sometimes. Whereas the volar was actually much easier to do. I just think the indications are less.
Yeah, no,
I don't know.
makes
What's
sense.
your experience? Have you done any?
I don't know. Like you said, I think we're still trying to figure stuff out. I'm not totally certain on what's the right algorithm for everything. And I'm not saying it's the right algorithm, but so what we've been doing for maybe the last year or so is you do the dorsal, and then you stick the probe in, and it still gaps volarly. I mean, you can like rotate it volarly. Then, but dorsally it's good. That's when sort of that's when, at least in my indication, for going volarly and then doing it volarly. I don't know if that's the right answer or not. I don't know if you need that. Would be an interesting study to see if you
It's
actually need that
hard.
or not.
How do you, I would think it'd be hard to do the volar because you've already tightened everything down dorsally. Is it harder to pass the needles through, or you kind of just come more from like a dorsal to or distal to proximal?
No, look, kind of like you said, because what I've done, what I do is I tighten it through, but then I do this kind of like, so Lorenzo Merlini kind of modified Matalon's sort of knot, and I actually do this little modified niece knot thing. So you can kind of pull it down without actually tightening the knot. You can kind of pull it down, reduce it, and then feel it, but without actually like tying down the knot. And so you can kind of like mimic what it would be like when you tie down the knot. And so that's kind of what I do. And then so then you can like let go again, and then you can sort of pass it
I see. Oh, that
fully.
makes sense.
But yeah, I agree with you. Volar actually is, I do find a bit easier. The dorsal can be tricky, as the fellows on this can attest to. It can be tricky, especially if you try to get nice spread between your needles. That can be a bit tricky. Yeah, the gaps. Gosh, I don't know. I think if I have drive design, I have a hard time. I have done 1 or 2 the capsulodesis, but I just have a hard time thinking that's right. But you're probably right. You probably don't really matter whether it stays gapped, and it really matters like as long as you correct the DC, as long as you correct the dorsal translation. But that's probably the 2 symptomatic parts. You're probably right. So then, are you doing a 360 if you do have a chronic deformity with an irreducible scapholunate, or what's your preferred reconstruction?
Yeah, the 360.
And do you
Or I
use
try to
the
convince
interference anchors?
Yeah, I'm sorry, what?
Do you use the interference screws like Sanj?
Like Sanj, yeah.
Yeah.
I'm a big Sanj disciple, so
Yeah, very good.
I follow his word to the. But I mean, I try to these patients. I mean, I'll say, look, let's do a synovectomy and do a deinnervation, and let's see how you do. Buy you 5 years, and let's do a salvage. I really like. So I won't. If I think. I don't like to go in at the time of surgery and then transition to a big open 360. I tell patients, look, I'm going to try to do this arthroscopically. If I get in and I really don't think you can, we're going to come back another day. Because just the timing of it all, it's from just a preparatory component, and mentally, emotionally, all those things. And so if I think I'm going to do that, I will then do like a de-innervation, a wrist de-innervation and a synovectomy. And then I say, look, we have to come back another day. Let's give this a couple months to quiet down. And a lot of patients do get enough relief and they kind of go on their way and don't want to come back 6 weeks later for a 360.
Yeah.
You know, if they're 18 or something like that, I'm a little bit more pushy, obviously.
Yeah.
But yeah, I mean, I don't even know if the Anafab and 360 and all these things are really the answer either, though. So I think there's still lots of great debate for all of it. I will say for the fellows and residents, you know, these are really tough scopes. And so I think one of the best things you can do if you're interested in doing this stuff is just get the reps in for your scopes in general. So start scoping dorsal ganglion, start scoping, you know, things that you wouldn't maybe typically do arthroscopically, just to start getting more and more comfortable so that when you do have some of these more complex things, you have those reps in. And that'll make you a lot more comfortable. Because a lot of these, especially if, you know, the lunate, if they're sitting in a little bit of DC, it could be really hard to maneuver the scope. I mean, it really gets in your way. So definitely don't have this be your first case in practice is my point, you know? And so for me, dorsal ganglions really help me get comfortable with scoping. Because, you know, if you get in a bind or you can't find it, you just make a little incision, you're taking out the ganglion anyway, but you have to, usually with dorsal ganglions, you usually make your ulnar portal first. And so that kind of makes your brain have to think a bit differently. And, so just try to get as many reps in as you can with some of the more simpler things before you go and try to reduce fractures, you know, and do arthroscopic scaphoids and do this kind of stuff.
Yeah, I mean, I can agree with that more. It's always hard if you're like only time you ever scope is on the super hard cases.
Yeah.
And you never scope on the easy ones. It makes it super hard for everybody.
Absolutely. It's pain. Those are the times you're like, I'm never scoping anything again. And then, yeah.
Exactly. Actually, you know, you mentioned innovation, and Gatchuk unfortunately is on a trip right now, so he couldn't be here. But I have to ask this question because he is a huge fan of denervating like everything. So like if he could just denervate everybody's wrist that comes through the clinic, he would. What is your indication for denervation not in arthritis, but in this? Because he and I have this debate all the time, where like I think it's great for the arthritis, especially if you respond to the injection, but I'm like this. That's an arthritic procedure. I personally don't do it outside of arthritis, but he had very vehemently disagrees with me and thinks there's a big role for stuff like this, like the SL stuff and some other stuff. What's your role for denervation when you apply it? Like when you either add it in as a secondary procedure or do it as a primary procedure in some of these non-arthritic cases.
Yeah, no, I'm more with you. I mean, I love de-innervation. I do a lot of CMC innervation. I've started to do some PIP de-innervations. I do, you know, obviously I'll do a wrist de-innervation anytime you're working on the wrist. So fusion, you know, for big arthritic salvage fusions or, you know, anything like that. I think it's tough when you're just looking at soft tissue. You know, Elizabeth Haggard has a lot of data talking about de-innervations and kind of the proprioceptive roles and some of that kind of stuff. So, you know, I do wonder about how de-innervating a joint in non-arthritic joint impacts the whole proprioception of the joint and kind of some of the mechanics. I don't really think we understand that. In this patient population, like these kind of instabilities, like, you know, I think I'm more apt to de-innervate than not because I hate the big reconstructions of, and so I think I'm biased towards trying to do anything I can to prevent that. But that would probably be the only time. I mean, if someone has CMC laxity or they, you know, instability in other joints, I'm not de-innervating in that realm. I love de-innervation for arthritic joints, and I've really pushed the envelope. CMC in stage 4, I've de-innervated, you know. But I think even with CMC, there's been a lot of data show the de-innervations don't work if they have instability, you know, and part of that's because, you know, the joint's still moving, but it does make me wonder if you're impacting the proprioception more, and then that is impacting it. So I'd be a little hesitant to wrist that has a lot of instability to just de-innervate it. But if you're in there doing a synovectomy, I think somehow you kind of de-innervate it just from doing, you know, thermal capsulorrhaphy as well. You know, when you kind of buzz the whole dorsal capsule, you're really de-innervating it, whether you really formally take out the PIN and AIN. So I don't know if I have a great answer for that, but when it comes to arthritis, I love it. I would de-innervate everything too.
Yeah. Cool.
So.
Amazing. Any other questions anybody has? Meredith, one note, if you have any interest at all, we're doing this results study. Maybe you have heard of it, maybe you haven't, but it's a multi-center like SL study on like Scott Wolf was heading it, and he
we're part of that, I think.
Oh, you are part of it. Oh, perfect.
I think so. Yeah, the Scott Wolf. Yeah, I think Andy Miller was heading that. It started like a year and a half or 2 years ago, something like that.
Yes, and kind of lost a bit of traction. We took it over, kind of leading it to try to I guess reinvent it. But there's like currently it's like all NFAB and that's it. Basically, it's the NFAB and then it's like us. So there's like multiple centers doing all this open stuff, and then it's us. So it would be amazing if you don't mind including some of these patients that you're doing. It would be awesome to have more than just one center doing scope stuff. So
yeah, no, that's a good reminder. So I think they have some of them in there, but yeah, we have.
Perfect. If you don't mind, that would be awesome. And it'd be really cool. And also like as a secondary product, getting them signed up and getting the outcomes, like you and I then could very easily sort of collaborate on whatever it is questions we want to ask. Because we have all the same outcomes.
There are a lot of people toying with this stuff now. It's just the numbers for each individual surgeon aren't there. So it really has to come together to get some of this this data. Because a lot of it's all out of Europe now. I mean, there's really not a lot from us right now.
For sure. But yeah, anyways, well, cool. So yeah, think about it, but and let me know if there's anything I can do to help that, because it'd be really cool to collaborate with you on some of this stuff. So
yeah, for sure. Thank you guys so much for having me. I hope I kept you entertained, and I appreciate